Hello and welcome to YouMatter. Hi, welcome to session 35 of YouMatter. This is the first, in audio, first official clinician and episode. I realise in hindsight I've done clinician and other things, but this is the first official one in that series. And the topic is being a clinician and a type 1 diabetic. My guest is Felicity Thow. You'll hear in this recording that I spend most of the session being educated at high speed and appreciating my own ignorance about type 1 diabetes. And the conversation brings up so many useful aspects around how we relate to people and quite often judge people with, in this case specifically, diabetes, but our conversation translates to other long-term chronic conditions. I got loads of education about how much work is actually involved in being a type 1 diabetic, and also really surprised actually how much relevance that has to Felicity's situation as a clinician. So really great topic to have as the first one of the clinician and series. Let me know what you think. I'm going to come back at the end, and I'm going to invite you to think about what other clinician and episodes might be relevant. But listen to this one and it might trigger some thoughts as to what other topics might be relevant in this series. Sit back, enjoy, and I will be back at the end. Hello and welcome to session 35 of YouMatter, where I am sitting here with my good friend Felicity Thow, who answered the call to come on this series of Clinician and Felicity's and is being a diabetic. So a clinician and a diabetic. So welcome, Flick. Hello.
Thank you.
To see you again.
I thought I was going to be clinician and Newcastle United fan, so
well, you have come dressed for that, haven't
you? Yes.
But I'm happy
to talk about type 1 diabetes in my Sam Fender outfit.
Actually, clinician and Sam Fender fan. Let's totally change the topic of the podcast and do that.
Brilliant.
Maybe Sam Fender's diabetic and we can merge the two.
He's got a health condition because he wrote Howden Aldi death queue about his NHS letter, so maybe
I'll get him on YouMatter next. No, I'm afraid you have to talk about being a clinician and being diabetic. There's no getting around it.
No problem.
But I do like Sam Fender talk. So let's go straight in. Tell me about being diabetic, and specifically, when did you get diagnosed? What's your particular type 1 diabetes story?
Well, I was a clinician before I was a diabetic. Most people with type 1 are diagnosed as kids, but you don't have to be. I met a 40-year-old woman who had just been diagnosed. I was 22, so I was newly qualified, about a year qualified, and I was on an elderly rehab rotation. It was my first out of trust rotation, so I was working for a big teaching hospital in Birmingham, and it had been intense. And then you get the odd rotation that was outside of the hive of activity of the big hospital, and I was walking an hour there and an hour back because partly because it was a nice enough walk through the autumn, through a big park, and also because I had better things to spend my new salary on, like going out and the Bullring shopping centre. So I thought, I'll just walk. And so I wasn't surprised that I was a bit tired. But I remember walking to work and going up the stairs of the hospital thinking, God, my quads feel fatigued, like more fatigued than I might expect from just an hour's walk as a otherwise healthy 22-year-old person. And I also remember having a sensation in the park. I remember where I was thinking, I just don't feel right, but I couldn't pin anything on it. I'd go to a GP and just say, I have no symptoms, but I just don't feel right. And they'd be like, oh, okay, 22-year-old girl, like, is it anxiety? And so I never really, I just kind of pushed on until one week, I developed a UTI, and I sat on it for a week, and I thought this will just go away in time, and it didn't. It got worse, and I remember one Friday, I had back pain. I thought, this is in my kidneys. I probably should get this looked at. So I got an emergency GP appointment at 5 o'clock that night. Walked my hour back there, and so I had it was the practice nurse who took a urine sample and said, yes, you have an infection, but we've dipped this for glucose, and the scale is kind of light green to dark green, and yours is off the scale, yours is black. Any reason why that would be? Like, I don't know. Like, he's obviously starting to think might be diabetic person. Of course, I'm thinking, are you going to give me anything for this back pain and this acute infection that I've come with? So they tested my finger with a finger prick blood test, and my blood sugar was 12. A normal non-diabetic blood sugar would be between like 4 and maybe 7 or maybe 8 if you've just eaten. 4 to 6 is probably your standard. So 12 was high. So he says, right, well, you're gonna have to go away and fast overnight, and come back tomorrow morning and we'll retest this. So I did, came back having not eaten since my tea, and finger prick blood test was still 12. So they said, oh, well, you'll have to speak to your GP. So the GP saw me, and I suspect was just simply blinded by the fact that I was 22 and just saw twos and said, you're type 2 diabetic. And I had no other risk factors, not one other risk factor, other than I had a blood sugar of 12. Like, not one other, my ethnicity, my age, my body type, not my lifestyle, none of it matched. But they said, you're type 2. Here's some metformin. Here is no means of testing your blood sugar. I didn't get a kit or anything like that. And then one GP told me you must cut out all sugar, which isn't even the advice for type 2 diabetes. It's carbohydrates you want to be looking at, but yeah, cut out all sugar. And then a later GP, I went back to the doctors and I said, I'm standing in Sainsbury's almost crying because I'm looking at pasta sauce and it says of which sugars. How on earth, what am I meant to eat? And they said, oh, well, you know what, there's no such thing really as a diabetic diet. It's more of a cardiovascular diet that we should all be. I was thinking, like, what? What does that mean? I'm a healthcare professional. What is a cardiovascular diet? So fortunately, I'm still on this rotation, with a bunch of very clued up junior doctors, on the ward. And they're listening to what I'm telling them and saying, I don't think this seems right. You haven't had a blood test per se. You've had a finger prick test, fasting there, but I don't think you've been diagnosed properly. And they'd said they were going to send me to the diabetes centre as well, GP. To this day, I'm waiting for that referral for my type 2 diabetes. And so I was advised by the doctors on my rotation to get a second opinion, which I did. And the GP was like, oh, brilliant, I've just done my exams on diabetes.
Okay.
Great. So she said, she tested my blood sugars then, and they were at this point 19. So you need to go to the diabetic centre. You need to, I'm on metformin, it's clearly doing nothing because I've got no insulin. And I can talk about the difference between type 1 and type 2 as well, because that's something I've definitely learned. So I got to the diabetes centre with this blood sugar of 19, and I was on insulin. They gave me an injection of insulin there and then I came back the next day and was prescribed it and talked to about everything. Because that's the thing with type 1 diabetes. It's like, this is serious stuff. Like, this is some serious medication that you have to take every single day and you have to get it right. I'm really pleased I was where I was 22. I had no dependents, really was, had clued up housemates who were also healthcare professionals. I was on a much more relaxed rotation than I had been in the hospital. It was a good time of life to be landed with something like this. I'm so pleased I wasn't a child. I'm so pleased I wasn't a student. I'm so pleased I wasn't older. It just was, it was a good time, if I was going to get it. So yes, that was me. So that took between the October and the December of the year I was 22, which I forget, maybe 2010. And I'm 36 now, so it's been a while.
Mm. Wow, yeah, it's quite a story, isn't it? And
Yeah,
you hope quite an unusual one.
you do. but also thank goodness I wasn't in a coma, because that would have just,
Yeah.
people often say, oh, you must have been undiagnosed for a long time. And I actually don't think I was. I
Right.
think I was, I think I was asymptomatic because it was so new. And 12, when you tested my blood sugars and it was 12, it's kind of not the be all and end all. Like I might be 12 right now and it's not a big deal. So long as it's not there at 12 all the time, like 12 is not catastrophically high. Like you're not calling an ambulance at
Mm.
12.
Mm.
I mean, you're calling an ambulance if you think someone's type 1 undiagnosed, but that's another story. But it was it, that would have just gone on and on and on. My blood sugars would have got higher and higher past 19, and then I would have gone into ketoacidosis,
Yeah.
and that's a coma, and that's how most people get diagnosed. I
Is
don't
it? I was
say
going to
most,
ask you,
a lot.
is that, I mean, that is the classic story that you hear, isn't it? But
Yeah,
is that genuinely the most common scenario that somebody goes into that
it
state?
that's a good question. Actually, I can't say for sure that is the most common, but that's what I tend to hear with diagnosis
Mm.
stories is people are seriously ill by the end of it. And it's funny because when I was in that time, so I had those 2 months between, it was a bit less than 2 months, it was kind of maybe middle of October till the 2nd of December, which is when I got put on insulin. It included a very fun birthday. So the symptoms, as I say, I had no symptoms other than feeling a bit tired, a bit fatigued in my quads when I climbed stairs. Suddenly, I was waking up in the night and I had to have a drink because I was so thirsty, and I couldn't do that walk, that hour's walk. But I couldn't do it without stopping at the petrol station halfway and getting a drink of water. It was it was weird. Like that's when I started to develop symptoms, and that
Mm.
probably would have been what I would have put two and two together and thought. Well, I probably wouldn't have thought diabetes, but I probably would have thought, oh, I'm not quite right. Um, the other thing I'd had was in the previous rotation, I was on outpatients, and I used to get to lunchtime and feel really not faint, but what turns out to probably be relatively hypoglycemic.
Mm.
So I wouldn't have been hypo, but the diabetic nurse suggested I was probably going from a really high blood sugar to still a very high blood sugar, but because I had such a weighted, maybe I was going from 12 to 6,
Mm.
which is much bigger drop than the person who's going from 6 to 5.5 as a non-diabetic. So I was feeling that drop and I'd have to eat. And it was difficult because I was an outpatient, so I had to wait until lunchtime. So yes, all in all, but yeah, so I developed symptoms eventually, but they weren't terrible, and they were when I kind of was suspicious of what I was dealing with.
When you look back, so having eventually got that diagnosis, did you do any sort of retrospective analysis of when you were much younger, like when you were a child playing sport at school or anything? Is there anything you can kind of go, oh yeah, actually that wasn't like everybody else and there was a pattern, or is there literally nothing?
Not at all, no. And I wouldn't have been diabetic then. It wouldn't have gone undiagnosed for
Right.
very long. But I do think I was probably early, and I'd had earlier that autumn I'd had a vomiting bug, and I wonder if that was an infection that then became an autoimmune thing. Whether it was the UTI itself, that seems very fast. I don't know, but yeah, nothing as a kid, and
Mhm.
it's nothing in the family either. Nothing that would have suggested
Yeah. Gosh,
diabetes.
what a bizarre few months.
Yeah, yeah.
So you got your insulin. How did things go from there? And particularly perhaps if you could talk about it in relation to your work as a physio, if there was any direct relationship.
Yeah, so you get put on two types of insulin as a type 1, a long acting, which you inject. I inject it at 9 o'clock at night because it's a convenient time, um, and that kind of is in your system for 24 hours. It's a long acting, and so it tides you over between meals. And then you take a short acting insulin, which lasts about 4 hours, peaks at about 2 hours, and you take that with meals. And if only it was a matter of them sitting you down and saying, take this dose with meals and this dose with at 9 o'clock, but it's really not. There's so much learning to do. You've got to figure out what your dose is at night. I've no idea how we did that. We just must have picked a number and then titrated it up or down. Then the food stuff, it's I inject currently 1 unit of insulin for every 10 grams of carbs I eat, which means looking at a plate and estimating that and then thinking, what am I going to eat after this as well? Like it's impossible. It totally changes your relationship with food. So and not in the way that people think. People often are, this was the best bit of being diagnosed diabetic, going back to the wards in the big hospital, and everyone would say, Felicity, you must go for lunch, at 12 o'clock on the dot, or you must go for the early lunch because you're diabetic. And I'd be like, great, I'm absolutely ravenous. Nothing to do with diabetes. It's kind of not how it works. If you're falling off a cliff at meal times, that's something to change with their insulin. That's my problem to change with my insulin dose.
But you were happy to go for lunch at
I'm
midday.
delighted with that. So yes, please, I'll have my lunch. I'm just hungry, like thank you for letting me go for my lunch. But I remember having to, those tunics. I could never get away with the polo shirt. I needed the tunic because suddenly I had the test kit, which was about the shape, the size of a wallet, with this blood sugar test kit and the blood, the strips and the finger pricker that was in there. I also had a stack of dextrose lozenges that would be in there, and you just suddenly have a load of stuff. I don't think I would carry my insulin around. I think I would always have to go to my locker, take it to lunch, and then go back. But you do end up just carting a load of stuff around. And I remember the head of physio. She didn't give this feedback directly to me, but I heard it from other senior physios above me, and she said, it makes me mad to this day, because she said, oh, isn't it great that Felicity got this diagnosis and she's just kind of slipped into it, and I didn't take any time off. I didn't say, oh, I can't do on calls for at the minute because I'm figuring out my blood sugars through the night. And I'm like, I don't know, should we celebrate that? Oh, well done you for not making any inconvenience with this major diagnosis to the running of our department. Like, at the time I thought, oh yay, good. I'm a good physio. I'm a good physio, and I'm a good band five, and I'm a good diabetic. But yeah, I'm a bit like, I don't know, let's maybe not.
And have you had the opportunity since to talk to anybody, going through that process, and with hindsight being able to say, don't push yourself in this time, or don't underestimate how difficult it is to manage this balancing phase?
I think I've heard. I don't think I've spoken directly to newly diagnosed type ones, but people who have them in their family, I tend to hear from them, and or patients, and you hear about newly diagnosed type ones. And I always say, like, it takes time. It really do. You don't just slip into it, as much as it looked like that to the head of physio. Because I kept going to work, of course. I'm still. I think a lot of people expect you to. Oh yeah, it'll be difficult at first, but then have you managed it now? Are you managing your blood sugars now? You have that tough time, and then it's fine. And it's not. It's constantly changing. Like, for instance, that plate of carbohydrates, I'm injected for those carbohydrates that I've guessed as well, if it's not labeled on the packet or what have you. But equally, I'm thinking, is my period next week? My blood sugars are probably running a bit higher, or have I just come back from a run, in which case I'm going to reduce my insulin, or I'm a bit stressed, my blood sugars are a bit higher. My blood sugar's a bit higher, and because maybe I'm coming down with something, or I am ill and they're higher, I'm going to increase my insulin. Oh, it's hotter, so my insulin's going to work faster, so I reduce it. I'm hungover, my liver is busy doing other stuff, I got to reduce my insulin then. The factors are, there's a list. I've seen a list on Instagram, and I can't remember how many it was, but there's stacks of things that can influence your blood glucose, that it's not just a matter of doing it for a bit and then being really good at it.
Yeah, gosh, you totally, to my shame, you've completely re-educated me just in the last 10 minutes. So yeah, I would have been in the camp of, you get diagnosed, you get your insulin, the insulin deals with it, job done, crack on with your life.
Yeah.
I did not realize there was that level of analysis needing to go on in addition. And I actually, again, to my shame, didn't even realize that you would change the insulin dose. So
yeah.
once you decided that was it every day, same thing.
And even the long, go on.
I was going to say, that answers a question which I didn't realize I wanted to ask you, but you kind of answered it anyway. So when you responded and said, oh, I want to talk about being a clinician and diabetic, that's really interesting, because this whole series is about the fact that clinician is a really strong identity, and yet we all carry these other identities with us. And just from what you've just explained, I can see how almost overnight that diabetic identity had to become very strong, because there was so much you had to think about. And it completely makes sense that you would respond to that call of, what other identities do you have?
Yeah.
Yeah, and I could easily have made the same mistake as your boss at that time. That, yeah, you just, yeah, well done, Felicity, she's obviously fine. Crack
Yeah,
on.
just rolled along with it. It's true, and have read it said before that you are your pancreas now as a type 1 diabetic. Your job is you have to keep yourself alive by doing the job that your pancreas used to do. And if you stop doing that job, you die. Or if you don't do that job well enough, you might die. Or at best, you might get some serious complications like losing your sight or your legs, or the sensation in your feet. It's a really like it's a lot, and I don't think we get enough credit, which I'm happy to kind of change on the podcast. But yes, I also, you know, I think there's a lot of shaming that goes on. Loads of people say to me, "Oh, but you're probably very good at managing your blood sugars." My brother's friend's diabetic, and he's like terrible.
Judgment.
So much. He's always drinking, and I always say, well, you are allowed. Like, he's allowed to live his life, but he's always eating this kind of food. Also allowed. There's no rules. There's no with type 1 in particular. With type 2, it might be different if you're told to cut down on certain carbohydrate in your diet. But with type 1, the nurse said to us, you go on a little course to learn to count carbohydrates. And she said, if you want to eat donuts every day for breakfast, that's your prerogative. She says, obviously, I'm going to, as a healthcare professional, say there are other healthcare concerns that you may not want to eat donuts every day for breakfast, but none of us should be eating donuts literally every day for breakfast. But with type 1, she's like, my job is to make sure that you know how much to inject for that donut for breakfast, rather than say, well, you can't eat that. But there's a lot of like, oh, you seem like a good diabetic, but my friend, and I think, wow, what's their crime is that they like to go out and drink, like
Yeah.
like all 20-odd-year-olds.
Well, I mean, actually, this is an extreme story. And I'll be careful about confidentiality, but at my kids' school this year, there was a teacher. Well, actually, it's been in the national news, so it's in that sphere. He was a diabetic, and he'd actually left their school last year and was working at a different school in Bristol. Went out on a Christmas work do, and went missing, and his body was found in the Bristol Channel on Sunday night, and no sort of foul play discovered, as far as they could tell. And the conclusion is probably that had a heavy session.
Yep.
He certainly was. The kids were all aware he was diabetic, and he talked about it a lot. And they would be a bit eye rolly about it. So what's going on about it? Having to eat stuff and blah 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 blah. But clearly that was a scenario that went very wrong. And probably just slipped in. It was the coldest night of the year. He slipped into the ice cold water. Yeah. So yes, it sounds dramatic, doesn't it? Well, people might think it sounds dramatic when you say you could die, but
you're completely. Yeah, it's such a difficult balance for me to strike, because I'm very much wanting everyone to think at all times that I'm fine. I'm fine, and I've got it. Much like everything in my life, I'm fine. I don't need any help. I'm totally fine. But I also, at the same time, want them to understand that it's like, it is very serious, and I'm doing a lot to ensure my own safety. But it's totally fine. I don't need to worry, but I also want some credit. It's a real balance. Like, it pisses me off when people are like, "Oh, you've had a lot to drink. Should you be injected? I'm like, "Oh, pardon me. What would you advise? Like, I've been doing this since I was 22. What would you suggest that I should you be eating that? Oh, I'm so sorry. Like,
it's a whole another layer to just healthy eating or lifestyle, isn't it?
Oh, it is. Yeah. I remember one boss at work had come in and they'd brought bagels for the team. Says, "Oh, Felicity, can you have one of these bagels?" And my response is always, "Oh, why? Are they poisoned?" Because I know I can't eat things that are poisoned. But yes, I can eat a bagel. Leave me alone with my bagel.
Mm.
Yeah, there's a lot
Do you
of
know what, Flick, you just well, partly you just triggered in my head that I didn't introduce you and what you do at all, but I'm going to do it now because it relates to what I wanted to ask you. So sorry, everybody.
I forgot that as well.
Welcome to Felicity Thow. She's an MSK physio. Just rewind a bit. Felicity is an MSK physio who divides her time between working for herself as FT physio and for Flick and Pain. And Flick's been involved in the realm of chronic pain for a long time, and that's a bit I wanted to ask you about because I'm sure it's something you've considered, but I can see so many parallels with chronic pain and pacing and the judgment again, should you be doing that activity because you're going to regret it later, you're going to crash, and almost by implication that's going to have an effect on other people. So I'm putting words in your mouth, but has it made you think about other long-term chronic conditions and the judgments we place around people's activities and decision making?
Yeah, completely. Especially when I hear people say, "Oh, this type 1 diabetic behaves like this." I'm like, we're all just human beings, though, aren't we? And none of us are eating amazingly well or like living stress-free, super active lifestyles. No, nobody is perfect, but yet we expect our patients to live up to this standard. And that's not necessarily something I feel from the diabetic clinic or my own doctors, but I do feel it's something we do as healthcare professionals. It's yeah, I mean, I feel like I'm generally a fairly compassionate person. I don't think I needed a chronic health condition to understand somebody else's experience of a chronic health condition. But it definitely does make you acutely aware that we're all just trying our best. We're all just human.
Yeah, I mean, I don't know if you've heard the 2 episodes I did with Carly Gibson about being physio and diagnosis of neurodiversity,
Yeah,
dyslexia. And I mean, particularly the second one, Carly described the daily strategies and practices that are at play in her life to, yes, to make her own experience of her life easier, but I really was struck by how hard she's working to not cause other people problems.
yeah.
And she didn't describe it that way, but it's that effectively is one side of it. And all these unseen conditions where people are working very, very hard in the background to, I don't know if it's appear normal or to not cause problems, but you don't see how hard some people are working at all, do you?
It reminds me of it's a thing I have with patients at the minute. I've started running more, and my blood sugars are responding by being very much lower than normal because presumably I'm replenishing my glycogen stores quicker than usual, more than usual. So and I'm still getting used to it. I'm still getting used to reducing my dose. It's a trust thing as well because I'm terrified of high blood sugars more than I am of low because I could immediately treat a low, whereas high is what contributes to these long-term complications. It's a whole other thing. Anyway, I've not been quick to reduce my insulin doses for, say, my lunch, but I then go to work and I'll have a hypo at work, and that used to be diabetes used to be a really invisible illness. Now it's slightly more audible illness because of the sensor that I have. So I have a thing called a Libra on my arm, which if you've ever seen, it's like mine's just smaller than a 10 pence piece, a white disc on my arm. It sits in my interstitial
Everyone
fluid.
probably thinks it's your Zoe.
It's the same thing. It's the same thing. Zoe,
okay.
Zoe is weird, but like what? If you're not diabetic, just enjoy that. Don't obsess about your blood sugars. It makes me confused. So I have this Libra which talks to my phone via Bluetooth. And so when I no longer need to prick my fingers or scan it, it just tells my phone what my blood sugars are. So just open the app and I see it. And I have an alarm set. So it tells me when my blood sugars are going above 11 and it tells me when they're going below 4. I don't so much care at work if they're going above 11, but I definitely care if they're going below 4 because that's a hypo. And of course, like hypos feel a bit like you can lose your train of thought. It's really hard to push through. It's a bit like the feeling if you've ever exercised without eating as much before, and it's that kind of like shaky hand feeling. Yes, it is, and so I need to eat some gummy bears. So what's been happening a lot recently is in the middle of say an objective assessment, the alarm, which is the most annoying sound in the world, will go off like unignorable, and I'll have to pause that conversation and then be like, now that alarm, I am just going to have to check that. Don't be alarmed. It is a medical emergency, but it's fine. You stay calm. You're fine. I'm fine, but I do just have to eat precisely 10 gummy bears. I'd switch this alarm off 1 second, and then like the peak of people pleasing, and this like what I strive for is I eat those 10 gummy bears and I'm like, it's true or no, right? And then I'll come back to that conversation and like not miss a beat of it and go, so you were telling me about your cycle and your knee pain with that, like this is insane.
I've got them a gummy bear as well. Does it feed into that?
I'm just simply offering them a lot of reassurance that I'm not about to die. They don't need to call an ambulance. This is all going to be fine, providing I eat these 10 gummy bears. With suboptimal brain glucose, it's a ridiculous situation. But yeah, you've got to. The challenge for me is the goal I set myself is to just pick up that conversation right where we left off. Allow no doubt in their head that I wasn't paying attention or that this has affected my capacity to treat them and their condition in any way.
I so understand that. I'm sure every clinician listening will understand that. Without diabetes or a diagnosed condition, you just articulated what we do all the time, isn't it? It's that I'm the professional. I've got this. Don't worry. Yeah. You reminded me of a time. So my daughter this years ago, she had a fall in a games lesson at school and she fractured her wrist, but she also bashed her face and they thought she had a head injury. And there was a knock on the door. It was my last patient of the day. The practice manager said, Jo, she described that situation and she used the word potential head injury. And I went, okay, thank you, that's fine. I went back to finish off the technique, the therapy technique I was performing, and the patient looked at me. They'd heard the conversation. They went, Jo, stop. You need to go now.
Wow.
But oh my God, I'm ashamed to admit it. The professional overrode that clear emergency situation that I needed to go and deal with.
It is mad. Yeah. And to me as well, I'm also like, this is like a daily occurrence at this point, these hypos at work. And I don't need a lot of time, but yeah, it is like I desperately don't want to. I don't want to interfere with that person's amygdala amongst all of this, let's not make them feel threatened.
Have you found a way through this? Because clearly, that's a one-off dramatic situation for me, but this is something you're managing, on a regular basis. Have you found any ways to calm that professional reaction? Not yet.
No, not yet. I really want my approach has been to speak to my diabetic consultant. I had my annual review in January. The problem there is it's so like, have you tried reducing your insulin? Like, well, yes, but I also I haven't got the calculation right. I like 10 grams of carbs, 1 unit of insulin, and they'll say reduce it by 20 or 30%. I'm like, oh no, that sounds hard. Not hard, but I'm reluctant. It's scary to reduce your insulin and the thought of just going high, even though my alarm will tell me and I'll probably be fine. I will almost certainly be fine. It's just
that's the fix, isn't it? And yes, that's extremely critical information that you must have. But what you're describing is the mindset of I can't be seen to falter. I can't be seen to have anything that diminishes my bulletproof armory as this professional.
Yeah, I don't know if I'd ever have a way around that. I'd maybe step outside. I'd maybe go as far as that, but no further. but also I don't think I need to do much, but it is, yeah, it just feels important to me that the thing this person doesn't go away with is the story of how their physio had a hypo in the session.
So let me pick up on the Zoe thing, because
Mm,
obviously everybody and his dog has got a Zoe thing these days.
yeah.
I haven't, but I have significantly reduced my carb intake this year and appreciated the benefits of it.
Okay.
But yeah, no, that's a really interesting comment from you. Like, why, if you don't have to do it medically, then don't
Why
obsess about your sugars.
why do you care? They're perfectly. I hate the thing when people say, "Can we test my blood sugars?" I used to get it a lot when I didn't have the Libra, when I would just be finger pricking. Can we test mine? It's the worst game in the world. Like, yeah, we'll test yours. Oh, look, it's 5. You're not diabetic.
Yeah.
Well done.
Surprise, surprise.
Yeah, shock. Your homeostasis is working perfectly. Uh,
So is Zoe picking up? I haven't got the Zoe patch. I've got that. Is Zoe picking up small variations in normal, as far as you understand it?
so from what I understand, which I'm happy to be corrected by anyone who actually uses it, but I have seen non-diabetics graphs and there is fluctuations. So because a lot of people look at my graphs, I can show you. This is not very good podcast information, is it? But well, it's just I'll not show you because it's going high. But it's normal for it to go up and down with your meals and little things that happen through the day. And the great thing about non-diabetics is that your body is on top of that and it's going, oh well, I'll stop secreting insulin or I'll secrete glucagon instead, and it balances out. I just think wicked. Put your feet up and enjoy that meal. Within reason, of course, there's the bigger picture, isn't there? As I say, if we're all eating donuts for breakfast, that's not ideal. But I'm not so worried. There's a lot about spikes as well, and I don't know I personally just don't know yet the link between think something like type 2 diabetes and the spikes of blood glucose. But to my knowledge, the spike is going to be fairly normal because you've eaten, and it's going to be much less than my spike, which is, I love when people say I'm having a blood sugar crash. You're like, oh, are you? What, you've gone from like a 5 to a 4, and I just don't know whether, yeah, knowing about that, maybe just if you're worried about blood sugar spikes, maybe just don't eat a full packet of Haribo.
Or 10 gummy bears when you're not tired.
Yeah. But then again, eat them sometimes because probably fine. It's like it's like the Coke Zero thing. Like, don't drink, it's the aspartame, and I'm like, well, probably fine.
Yeah. So actually, like, I'm going to pause here because talking of bodily functions taking over, I'm desperate for a wee.
Fair enough.
So I'm going to do a Jack March now.
Yeah.
There we are. And go and have a wee, and then I won't be distracted by that.
I might get a drink because the blood sugar I was going to show you, it's because I overcorrected for that hypo on my run.
Yeah, you said
I might inject a unit and have a drink.
Let's leave this in because this is my bladder and your blood sugar. That we are humans as well as being clinicians. We'll get Jack to cut out the bit where I'm having a wee in your
the bit where we rustle around in the background. Yeah.
But let's go and do that.
Brilliant. See you in a bit.
See you in a bit.
Hello.
This is like the podcast version of live TV.
It is.
It's all happening.
It is.
I wouldn't like to say that me needing a wee is on a par with you potentially having a massive blood sugar
spike.
But
it's
we're all compromised.
High blood sugar is not an emergency really, so
it's the high
get by. Yeah.
So where I was going to go before being distracted by my bladder was you mentioned that you would make the distinction between type 2 and type 1, and I think that probably, so when we're talking about the Zoe and everybody these days obsessing about their blood sugar, we're almost drifting into that, oh, am I moving towards type 2 diabetic situation if I'm having insulin spikes and this, that and the other, aren't we? What's your thought around all of that, or what's the relevance here with type 1, type 2?
Well, it's sometimes it's interesting that they called them both diabetes because they're very different disease processes. that really the only similarity is the symptom, which is high blood glucose.
Mm.
And I remember being on that elderly rehab rotation, working with a lot of type 2 diabetics, because they'd often had amputations. So they'd had their amputation in the acute hospital, and then they'd been transferred to the rehab hospital to work on their mobility and their transfers and things in order to go home.
Mm.
And I remember thinking, gosh, I really must learn the difference between type 1 and type 2 diabetes. I really must learn. And the universe was like, oh, well, I'll tell you the difference. They've got type 2 and you've got type 1. I thought, oh, I'll definitely know the difference now. So, I mean, really, would it be useful to go over that? Like what the difference is?
So, yeah. Well, I'd like to.
Because I didn't know at the time. What I describe it as is so type 1, which is what I have, is a lack of insulin. The part of your pancreas, it's not the whole pancreas, it's a tiny percentage of your pancreas, stops working because of an autoimmune response, and you stop secreting insulin. And what I like to think of insulin as is the key to unlock your muscles and your organs to blood glucose. So you no longer have any keys to unlock. So your glucose is just in your blood, which is why you have high blood glucose. So you have all this energy, but you can't use it. You can't give it to your organs or your muscles. You can't use it for energy, which is why you end up tired. And then because you've got so much of it in your blood, your body starts rejecting it and you end up peeing it out, which is why you end up going to the toilet a lot and you end up really thirsty. And then the waste product of this high blood glucose is ketones, which is then what they test for in your urine. And that's what that buildup of ketones, you end up in what you call ketoacidosis, which is like a metabolic state.
And that would be the diabetic coma.
It would be yes, you end up in this acidotic state because of the buildup of ketones. So that's your type 1. You have no keys. You've just got a load of blood glucose sat there, a load of energy sat in the blood, not able to get in the organs. Whereas type 2, you have the keys, but your locks aren't great anymore. So the receptors, the things that the insulin interacts with, they're slower, they're rustier. And so you have all the keys you want. Some type 2 diabetics end up injecting insulin. I presume that's just to kind of boost. I don't know enough about type 2. Yeah, so I think if you the type 2 diabetics who have no injected insulin tend to really need that extra bit of help. So it's not a standard treatment for type 2 for everyone. But the medication like metformin aims to make those receptors more sensitive. And then the method of treating type 2 by reducing your carbs and increasing your activity levels also makes you more insulin receptive. So you as I'm finding, exercise makes me really sensitive to my injected insulin, whereas with type 2, it's a good way of managing your blood sugars, being more active, and also reducing the amount of carbs, so reducing the amount of work, I guess, that your receptors are having to do. And whereas type 1, so a lot of people say, oh, what if you just exercise more? Is this because you ate a lot of sweets as a kid? And you're like, oh, well, no, because it's an autoimmune thing. No. It also annoys me when I hear people shitting type 2s as well, because as I say, none of us are perfect people with our perfect diets and perfect activity levels. And it's a really hard thing to deal with, type 2, I think partly because of the stigma attached to it. I always worried that if I get older and put on weight and people know I'm diabetic, that they might assume I'm type 2 and I get shamed for that. I'm like, that's a crazy thing to do to people. But we do, and yet Halle Berry is type 2 diabetic. So Steve Redgrave is diabetic, and I think it's we're not sure. I don't think he's said whether he's type 1 or type 2, but there is some conversation that he might be type 2. So sometimes it is just genetic, or your ethnicity can contribute.
Other processes beyond, as you say, being overweight and having donuts for breakfast.
Yeah, and yet we really stigmatize people for their diagnosis, and it's just a hard thing to live. Imagine having to cut down your carbohydrates. That's really rubbish, and everyone constantly policing your diet as well.
Or you policing. I'm just thinking of two friends, two male friends of mine, similar age, who got diagnosed type 2 recently, both actually quite active people,
Yeah.
and not massively overweight, but they have both managed it brilliantly through diet. But I would say there's been when they got their diagnosis, they were hugely embarrassed. I remember them both telling me,
Yeah.
God, I've been diagnosed, I'm borderline type 2 diabetic, isn't that awful? And of course I'm going to deal with it and get on with it. And, both been on really extreme diets, and yes, done very well, been good boys, and I'm sure
Yeah.
not sat on the back from diabeticness. But yeah, you're right, and probably a bit extreme in the management, and I'm sure that's influenced by how they feel about it themselves, based on what society possibly feels about it, what they think society feels about it.
Big time. Yeah. Yeah. It's baffling, isn't it? It's a really
Definitely a
hard thing to
balance,
live with.
isn't there? Because we don't want to
Yeah.
go, okay, well, it's fine, everybody just get type 2 diabetic and don't worry about it. But
Yeah.
yeah, there's definitely a middle ground.
Yeah.
Really interesting. I have to say, much more interesting than I thought a conversation
Everyone,
was going to be about
I
diabetes.
find that with yeah, you think, oh, type diabetes, but I did an in-service on it once, and I think people were surprised and like, oh, right, this is interesting. One of the things I said to people was one of the things I stopped doing when I became diabetic was asking people, when we ask people about their medical history, any diabetes, specify type 1 or type 2, but whenever they say yes, the next question was always, and is it well controlled? I don't
Are
no
you being
longer
good?
ask that. Are you being good? Is it well controlled? But also, has anybody ever answered no? No, it's not well controlled.
Sugar's all
It's
over the
shocking.
place.
Or absolute roller coaster. I've never heard anyone say that. And also, well controlled is like it's such a big thing. You get an annual blood test of your HbA1c, which is your kind of a 3-month marker of your blood sugars. So it gives them an idea. I guess they used to use it when you were just writing down your blood sugars. You could go, oh, they're all perfect, and they'd go, well, your HbA1c says otherwise. But it's a bit of a snapshot of the past 3 months. And so you have that, but my HbA1c went down by about 4 points in January, which you'd think would be fantastic, but it was previously okay. Now it's like brilliant. But it's because I keep having these very annoying hypos, 3-4 times a day because of my running. And so it's not but anyway, the point I'm making is to sum up whether my diabetes is well controlled at this moment in time. That's a huge question that I don't think we have time for in my assessment of my sports knee injury. So it's a funny thing. Like, are you prepared for the answer that this person might go, oh, well, my HbA1c is this? Like,
what are you going to do about it?
okay. I don't know what that means. Yeah.
No, I mean, my big takeaways, Flick, are that yes, there's a shed load more management involved than I had contemplated, and this really interesting piece, not specific to diabetes, but diabetes in a really great way
adjacent
to illustrate it, of this desperate need that we have to be the in control professional all the time. And if you're carrying clinician and anything, how you must never let that show, never let it affect.
Absolutely. You've got to pick up that conversation where you left off.
Yeah. Which we have got to manage, haven't we? Because we've got to find a way around that, because we all, we're not all diabetic, but we're all clinician and something.
Yeah.
And it will come out at some point with a patient. Yeah. One final question I wanted to ask you, which is cool because you're not there yet, I presume, but when you were saying in your hypo, oh, I get brain foggy and stumble over my words, I was thinking, yeah, sounds like menopause.
Yeah.
And I'm sure it's much more heightened than that. But do you know if there's any evidence that being diabetic and menopausal is problematic?
I don't know. Probably because they probably haven't done enough research into, either one. But all the things that I think my pressing concern is more about like overload injuries and bone density stuff, and thinking there's a lot of potential healthcare complications coming my way just because I'm type 1 diabetic. They say it shaves 20 years off your life expectancy just at diagnosis, like no matter how well you do, that just is. I don't know how true that is, and I've heard it a few times. But so maybe I won't have to worry about it for too long. That's what I always think. If I can get to 60 and then out, then great.
No, we need you around until you're 100.
No, because then I'd have to probably pay more into my pension pot as well. That's always my go-to. I'm like, whenever I start worrying too much, I think, oh well. Silver linings.
My husband was talking to an IFA about pension. He said, well, I can't rely on my assumption that I'm going to abuse myself so much that I'll die before I a really positive outlook.
Yeah. And if you want any life insurance as well, and you're type 1 diabetic, no can do.
It's a big deal, isn't it?
Can do. I just don't have it. Yeah, and it increases your holiday insurance cover. It's a real pain.
Yes. I am feeling very humbled and shamed here. It's so much more than I had got my head around. All right. Is there anything else you want to say about being a clinician and a diabetic?
I think one of the things, so I was expecting the question, what have you, like, being a patient, which I am when I'm diabetic at the clinic, has that changed how you are as a clinician, which we talked about as well. But I think actually the biggest thing has been being a clinician and working with people who live with things like chronic pain, because chronic pain is an interest of mine. Talking to people like that has actually changed how I am as a patient. So I'm much less likely now to be the people pleaser. As a patient, yeah, I'm like, I'm going to do the best I can with my diabetes because it's me, and B, it's my healthcare. It's within my interests to look after myself. But I am also much more likely now to advocate for myself and to say, that is a ridiculous suggestion that I will not be implementing. And that we do. We are healthcare professionals. We do suggest stupid things to people because we don't have to do them. For instance, my doctor has 2 doctors in a row now have said, well, have you thought about, there's 2 things I need to say. One is, have you thought about switching your alarm to go off when your blood sugar is 5? So a hypo is anything below 4, 3.9 below. Have you set your blood sugar alarm to go off at 5? I was like, if my blood sugar is 5, which is perfect, why would I want to know about that? I don't care. I'm getting on with my work. I'm getting on with my day.
Yeah, what do you do with that information?
Yeah, and there's arrows on it. So if it's plummeting, then okay, cool, I've got the heads up, but it's going to go off at 4 anyway. I'm going to deal with it then. But so sometimes it's 5 and just 5, or just 5 and stay there. It's 5 and it's going up. But it's yeah, it's just like, have you had an alarm that goes off whenever your blood sugar is optimum? It's so annoying.
Or anything else, any other bodily function which may or may not be perfect.
Yes. Shall we set your bladder to go off when you're like 75% needing the loo? Like, no, let's just.
Might be helpful in my case, clearly.
But it's yeah. And the other thing is when they want you to inject, split the dose at night. So sometimes my biggest meal will tend to be my evening meal. And then the problem with big evening meal, like pizza is my nemesis. I love pizza, but because there's so much fat in it and carbs, fat gets digested first, and then you end up with a very slow release. So if you want to avoid insulin spikes, blood glucose spikes, eat fatty foods. Eat pizza though. Eat pizza because it's going to be a much slower spike because the fat will get digested first. Now, this is all very well if your blood sugars are managed by your own insulin, because your own body's insulin will be counteracting that rise all the time. Whereas my insulin works like now. 2 hours and you're done. Well, 4 hours overall, but 2 hours with peaking. So I'm waking up at 2 a.m. with my blood sugar alarm going off saying, oh, here's your pizza. Here, you've got high blood sugars. And so one of the ways around that is to split your dose, which just sounds like a lot of maths to me. And I kind of get around it by just waking up at 2 o'clock in the morning and with my alarm and then injecting and go to sleep. but yeah, the suggestion is you inject for, say you were injecting 10 units for this pizza, you inject 4 or 5 with the pizza, and then 2 hours later you kind of calculate the rest of that, and then inject. And I'm just like, who wants to do that? I want my tea, and then I want to go to bed.
And bearing in mind, pizza is fairly often accompanied by an alcoholic beverage, which may or may
Absolutely,
not
yeah,
improve that whole
yeah. Set your alarm for 2 hours
thing.
time. Yeah, it's great, and often I'll be working till like maybe 7 or 8. I mean, my tea at 8 o'clock, half 8, 9. When 2 hours later, I want to be in bed. So I will often say, I think normally I'll be like, oh yeah, I'll try that. And I'm thinking, no, that will not work for me. So I'm much more likely to stick up for myself, I think.
Yes. And
And
as a clinician, I can, to bring it back to our clinical role, I
mm,
think, we talk a lot about partnering, and on the back of this conversation, I'm thinking, yes, and partnering sometimes means hearing the patient say, do you know what, that's a really stupid idea, and it doesn't fit with my lifestyle for this reason. And
yeah,
sucking that up and finding another way rather than just pushing our idealistic agenda.
yeah. Well, I wish they'd read it as like you'll then get that next time and next time, because it's a different. You tend to see the registrar, and who's a different, who's rotated since last year's annual review. Yeah, there's a lot of tick box, quite like, and do you plan to have a family?
Uh,
That's a whole other thing. I don't plan to have a family, but if I did, type 1 diabetes takes the romance and any spontaneity out of that. You've got to, the first person to know tends to be your diabetic nurse, as in that you're considering having a family. Um,
whole new
that
level of
just
family planning.
sounds a nightmare, diabetic pregnancy.
Yeah.
All the fun. There's so many fun parts, Joe. I can't believe you didn't know about them all.
Well, I've been continually ashamed through this podcast that I didn't. I feel we should talk about Sam Fender at the end, partly to lighten the atmosphere, and because you've worn
Yeah,
this jumper clearly for a reason. So,
yeah.
how's your Sam Fender life? Are you going to any gigs?
So I went to see him at St James's Park in the summer, and that was brilliant. And I was really jammy, and I went to 2 nights. And on
Is
the
that the
second
most
night,
Geordie thing you can possibly do? See Sam Fender in St
ex-
James's Park with your accent.
yes, and on the 9th of June, which was the Bladen Races Day, it was on the 9th of June. You might not know this
You
is a
picked up my blank expression there.
yeah.
Yeah.
And then the other, it was a real Geordie fest, because then he brought out Brian Johnson, and they sang Back in Black
Oh
and
wow.
All Night Long. I've seen St James's Park in some good times, like in some enjoyable states. I've never seen anything like this. The place was jumping. It was brilliant.
That sounds like a high point
It was
in a
very cool.
in
Very
a
cool.
Newcastle existence.
It was. Obviously, I was in a Newcastle shirt as well, so what a
Wow.
winner.
So future Sam plans, anything else in the offing?
Yeah,
Or have you
I
peaked?
suspect he might be releasing an album. I don't know when, maybe this year, maybe next, I don't know. Um, he's been quiet, so hopefully that's a good thing.
Yeah, something brewing in the background.
Yeah,
Well, thank you so much for educating me.
no problem.
Possibly more than anybody else listening to this. Maybe my level of ignorance is greater than the
No, I think it's
average
I
listener.
think it's fairly common to be like, oh well, yeah, you just inject. Like,
Yeah.
no. There's more to it.
Well, thank you, Flick, for talking about that. Partly to help us understand being diabetic and being a clinician, but also to bring up all those really thought-provoking points about people with unseen long-term chronic conditions, and how we treat them and how we treat ourselves when we're carrying things alongside being a clinician. Brilliant
Absolutely.
conversation. Thank you.
No problem. Thank you.
All right. Well, have a lovely weekend. And let's hope we get to meet and talk soon.
Definitely.
Cheers, folks.
Thanks, Joe.
Thanks for listening. I hope you enjoyed that conversation. As I said, I was educated a lot. Maybe I'm more ignorant than average on the subject of diabetes, particularly type 1 diabetes, but I if there were things that brought you up to speed, then that's all good. I hope there were things that you found useful and that you might be able to take into your clinical practice. And if you happen to be another clinician and type 1 diabetic, I hope there was some stuff there that was useful to hear. Let's hope this conversation helps to raise understanding and empathy for people managing this condition, not just alongside being a clinician, but whatever their professional role is in life. So this series, Clinician and it can extend to all sorts of things. It doesn't need to be clinician and a medical condition. It may just be clinician and the circumstance you find yourself in life. Maybe clinician and single parent, clinician and going through menopause, any number of things. If you recognize that there is an identity that sits alongside being a clinician that is either as strong or maybe even stronger, and you think it would be interesting to talk about in this series, then please do drop me a line and come and be a guest on that. If you are a clinician, and if you are a clinician and anything, trying to manage that condition alongside being a clinician, which generally involves trying to be all things to everybody in all spheres of life, then please remember that you are allowed to manage that condition, manage that state. You are allowed to fail, you are allowed to falter, because like everybody else, you matter.